My name is Dr. Cathy Eng, and I have the sincere pleasure of participating in this Anal Carcinoma Foundation Patient Summit. I am from Vanderbilt Ingram Cancer Center in Nashville, Tennessee, and today I was asked to discuss a review of treatment options for recurrent and metastatic anal carcinoma. So just to keep things in perspective, as many of you know, anal carcinoma still remains a fairly rare malignancy, although it has been increasing in incidence by 2.7% per year. And for approximately 10 to 20% of patients, they will present with metastatic disease. And then there'll be additional 10 to 20% of patients that may have failed chemoradiation therapy for earlier stage disease and end up with metastatic disease. So prior to 2017, these were basically the multiple treatment options that have been published at that time, the most recent being 2018, I apologize, by Dr. Kim, looking at a triplet regimen of chemotherapy. But obviously, as stated earlier, we need to find additional treatment options for our patient population. And so what else can we provide patients based upon the knowledge we had? Well, as many of you know, immunotherapy is now considered part of the standard of care for previously treated metastatic patients. The original data included two different drugs, one being pembrolizumab, and this was a study specifically in previously treated patients where the primary endpoint was looking at response. The response rate is about 10%, and they're suggested there may be some additional benefits in patients that had PD-L1 positivity or programmed death ligand 1 positivity. However, the data is not strong enough to suggest that that is required for response. This was basically the degree of tumor reduction that was noted. And we also conducted a study looking at nivolumab, also in a multi-institutional study. And basically what we noted was a response rate of about 24% and some very impressive results with one of the patients being clear of disease for several years. We've also looked at the role of atezolizumab, which is another immunotherapeutic agent in combination with bevacizumab, or otherwise known as Avastin for some of you. This was a pilot trial that we completed at MD Anderson Cancer Center. And that combination is a very promising combination in other malignancies, and it's now considered the standard of care for hepatocellular carcinoma. Here in this pilot study of 20 patients, the response rate was also a little disappointing at about 10% for the combination, and that was presented at the ESMO meeting last year. The progression-free survival was 4.1 months versus the median overall survival of 11.6 months. So what other options can we provide our patients? We've also previously looked retrospectively at the consideration of anti-EGFR therapy or epidermal growth factor receptor therapy. Anti-EGFR therapy is considered a standard of care for metastatic or surgically unresectable head and neck cancer. This was a small retrospective analysis at MD Anderson when I was previously there. It was in 56 patients. And basically we noted there was a response rate of about 41% and an improvement in progression-free survival or time to tumor growth of 4.3 months and a median overall survival of 16.1 months. Now, there are several pending and ongoing studies, and once again, in the interest of time, I'm trying to provide the best knowledge base for you to know what your options are in this setting. There is an ongoing study at MD Anderson looking at multiple different types of HPV-associated malignancies. This is a phase 2 study of VGX-3100, which is a DNA-based immune activator, which basically encodes for IL-12. It's given in combination with durvalumab, which is a standard of care in non-small cell lung carcinoma. And this trial is specifically looking for patients with cervical cancer, as well as other rare tumors such as anal carcinoma, penile cancer, vulvar cancer, and vaginal cancer. And cohort C is for HIV positive patients. They hope to enroll a total of 77 patients, and when I just checked yesterday, this trial is still open. Now, what about vaccine-inspired therapy or other types of immunomodulated therapy? There is an ongoing phase 1 study called the SQUEEZE study that is being conducted at multiple centers. Once again, also in HPV subtype 16 positive patients. And they have to be HLA-E2 positive, which is about 20 to 30% of patients. This is not only looking at the single agent, but also in combination with immunotherapy. Once again, this trial is ongoing and is available at multiple institutions. There is data to suggest that, once again, as I mentioned earlier, the role of avelumab plus or minus cetuximab, this is a study being conducted overseas, so immunotherapy in combination with anti-EGFR therapy. This is looking at, once again, surgically unresectable patients. Patients are subjected to either immunotherapy alone or the combination with anti-EGFR therapy. The response rate is the primary endpoint, and they enrolled 54 patients. They also did allow HIV positive patients. This trial has already completed enrollment, and we are waiting for those results. I think it's very important to keep in mind that a lot of the trials that I'm showing you today originally did not allow HIV positive patients in many of the earlier pivotal studies. And that is because they were fearful that these patients would not fare as well and that they may negatively impact the overall survival of ongoing trials. However, I think we've obviously learned these patients, if they're adequately treated with retroviral therapy or do not have any significant HIV viral load, they are excellent candidates to participate in clinical trials for metastatic anal cancer. We have an ongoing trial, which is the second portion of the original trial that I mentioned to you of nivolumab. This is now still a multi-institutional study looking at nivolumab plus or minus ipilimumab, so the CTLA-4 inhibitor for refractory or previously treated metastatic anal carcinoma patients. This trial is actually nearly completed. It will be a total of 100 patients, and we hope to report it out next year. Other trials. So you should be aware that basically the earlier work from Dr. Kim looking at the combination of chemotherapy plus the consideration of immunotherapy is being pursued. He's conducting a small phase 2 study of docetaxel plus cisplatin plus 5-FU plus or minus atezolizumab in a 2-to-1 randomization of about 99 patients, and it does allow HIV positive patients. This trial is ongoing and is currently enrolling. The primary endpoint is progression-free survival. As many of you are aware that we've already previously reported the results based upon the International Rare Cancer Initiatives, which was a global study looking at newly diagnosed metastatic anal carcinoma patients. This compared cisplatin plus 5-FU versus carboplatin plus weekly paclitaxel. This enrolled a little less than 100 patients. The primary endpoint was response rate. We published this in JCO in 2020. And what we noted was, in fact, the response rate was comparable for the two regimens between 57 and 59%. The progression-free survival was in favor of the carboplatin plus paclitaxel, although not statistically significant, and the median overall survival was favorable for carboplatin plus weekly paclitaxel. Keeping in mind that in the United States, immune checkpoint inhibition or immunotherapy was available. The median follow-up was 25.3 months. And as a result of this randomized phase 2 study, it created a new standard of care in the United States for newly diagnosed patients, because carboplatin plus weekly paclitaxel was noted to have less side effects with comparable response. As a result, there is an ongoing trial that is largely overseas of carboplatin plus weekly paclitaxel with retifanlimab, which is called Interact Part 2 versus placebo in patients with locally advanced or surgically unresectable disease. Patients are randomized in a 1-to-1 fashion with the consideration of basically chemotherapy plus or minus immunotherapy. The primary endpoint is progression-free survival. And they hope to enroll 300 patients. We in the United States here created our own trial, which is supported by the NCI as well as ECOG. This is basically also looking at carboplatin plus weekly paclitaxel in treatment-naive patients. It does allow HIV positive patients. Patients are randomized in a 2-to-1 fashion to the investigational arm with the inclusion of immunotherapy. So carboplatin plus weekly paclitaxel plus or minus nivolumab in a 2-to-1 randomization with the hopes of enrolling a total of 205 patients after completing 6 months of systemic chemotherapy plus immunotherapy. If you're on the investigational arm, you are then allowed to continue the immunotherapy as a maintenance regimen. And the primary endpoint here is also progression-free survival. Now, I want to mention to you some of the correlative work that has been conducted in some of the trials thus far. And this is some of the work we conducted when I was at MD Anderson, noting that there was no difference in tumor burden for response to immunotherapy. Tumor mutation burden has been found to be helpful in other malignancies, but not so much in metastatic squamous cell carcinoma of the anal canal. There appears to be some very promising data based upon the data from the French group looking at the role of HPV circulating tumor DNA in metastatic anal cancer, and noting if there's any improvement in your level of HPV circulating tumor DNA, this may correlate with benefit of response. And this is as demonstrated here. Once again, small numbers, 36 patients. They noted that basically the more dramatic the change, obviously, the more likelihood of having benefit of therapy. So in our clinical trial of EA2176, and please note I am in full disclosure, the national investigator. This is basically based upon a lot of the work that I've been conducting over the past several years since initiating my career, looking at this patient population, which I felt was an unmet need, trying to identify different treatment options for my patients. Our goal is to basically improve the progression-free survival of 8 months to 12.8 months. Once again, we hope to enroll 205 patients, and it is a 2-to-1 randomization that you will end up in the investigational arm with immunotherapy. As a result of the promising data with HPV circulating tumor DNA, I have included that as a correlative for our clinical trial as well. And we are working in conjunction with Sysmex Diagnostics, as well as with the support of the Farrah Fawcett Foundation for funding this trial in regards to the correlative work. So in conclusion, there's no definitive evidence that PD-L1 expression is predictive for immune checkpoint inhibition in metastatic anal carcinoma. HPV circulating tumor DNA is a promising marker in metastatic head and neck cancer and appears to be beneficial in metastatic anal carcinoma as well in regards to progression-free survival, relapse-free survival, and overall survival. Chemotherapy is considered a standard of care for frontline patients, but now we are looking at the combination with immunotherapy because it has been found to be beneficial in other malignancies. And I always encourage people to enroll to a clinical trial whenever possible to make greater and faster advances in a rare cancer, specifically of that for metastatic anal carcinoma. So I'd like to thank you for your attention. I hope I was able to collect all the data as best as possible in the 15 minutes that I was allowed to conduct this lecture. So I wish you all well, and I'm sorry I could not be there today. I am away at a leadership conference myself, but I hope that you learned from some of this information provided to you, and please reach out to me if you have any additional questions. So thank you so much for your attention.